Thank you. All right. Well, this is a first for me, following a comedian, so it's going to be a lot of pressure. Dr. Dong was a little bit of a comedian this morning as well, I'd say. But more than a little bit. That was terrific. Well, I appreciate being here. Caroline, thank you for allowing me to be here to share some thoughts. It's great to see the young faces, and you guys have been attentive, and that's tremendous, and it was a great way to start off the morning. As I said, I'm Joe Flynn, and let's see. So this is what we're going to try to cover, and I'm going to stay to the 45 minutes, and like Dr. Dong, I can be a little bit of a freewheeling, so I'll try to stay on. I'll keep myself on, but if I see people fall asleep, I'll ask them questions, and I will try to keep things going. God bless you. As I sit and we hear about the different discussions today, I love the history of medicine. And when you think of the history of medicine, it's not that old. And you guys are thinking like, all right, old man, sure, but I'm going to prove it to you. I won't ask you specific things, but I'm going to, hopefully you're going to leave with some higher level understanding of how we got to where we are and really where I think we need to go and the importance. So we'll talk about what is research. You say research, and probably everyone has a little bit of a different understanding or thought. But really, I want you to think about research as it's about the individual. You heard about with Annie, she gave a great understanding of what her journey was, right? And some of those real aspects of things, and that's what we're going to really be focused on today. So if you hear nothing else, if you zone out and you start thinking about what you're doing this weekend, know this: no one receives a treatment for cancer, any cancer, without having somebody else having been on a clinical trial. Now, the reason I'm standing here is I think everyone should be offered a clinical trial. Now, not everyone's going to get on a clinical trial, but everyone should be offered one. And I think people, if they're concerned, they should get a second opinion. I just think that it's about them and not about us. And the us, and the bigger us in healthcare, can overwhelm that. So if you know nothing else, nobody gets treated with anything without somebody having gone on a clinical trial. So we owe a lot to those patients, and I'm always grateful and I always say prayer for the people that are on our trials, because if it weren't for them, none of this would happen. So what's cancer? We sat here now for a couple hours and everyone's talking about breast cancer, and what is it? Well, I'm going to give you the one that's the easiest. This is kind of a nice cartoon that explains the genetic mutagenesis and insults, etc., and it goes from normal cells to abnormal. But cancer is just either the cells are growing fast or they look funny or both. So they don't look what they're supposed to look like. They're growing uncontrollably because there's cells that have these natural cell death spaces, and that's really drives us on how we decide how we're going to treat. We look at those mechanisms, as we're going to talk about some treatments, it really is around that. In high school, do they teach cell cycle now? Yeah, right? Until not that long, it was all about the cell cycle, and we'll talk about that. Not in depth. I don't want people falling asleep. I look at this group, but these guys are already asleep. All right, Dr. Dupree showed this. Breast cancer is the most common cancer in women, second most common cause of cancer death in women. Rates continue to rise, incidence rates, and the part that's troubling is that there's a 1.4% increase per year in diagnosing women under age 50. So the number one risk factor for cancer is age. 70-ish% of all cancers are in people over age 65. So age, right, that's, hopefully we all age, so we're all going to face those risks. But we're starting to see cancers in younger people. Look at colon cancer, but in breast cancer. And how the youngest breast cancer, I'll remember to the day I died, a 19-year-old who just had a baby, who they thought she was having mastitis, 19 years old, and she was found to have metastatic breast cancer. So her little baby was sitting outside the chemo room while the mom was getting chemo at 19 years old. Now that's unheard of. Well, it's not unheard of, you just heard it, but it's like extraordinarily rare, but it happens. And we're seeing more young people, and that's important. So in 2020, the estimates were around 168,000 women with metastatic breast cancer. That's a lot of people. That's just in the United States. 5-year survival for all those cancers are improving, and we'll show that here. And then Dr. Dong did a great job of showing those key studies, and if you understand he made a comment repeatedly, like, where does it change my practice? I'm summarizing, but basically that, does it change my practice? And you think about it, we live and die by these studies that supposedly are altering our practice, but how do you do that? Right? Not every drug gets FDA approved that we use for certain diseases. If you have 2 phase 2 studies or 1 phase 3, we will use that drug in a cancer without getting FDA approval. So how do we make those determinations? In some studies, they'll have 10,000 women in the studies, and so the power is so strong that just a small change is statistically significant. How do you incorporate that based off of years? I mean, I often have patients after ASCO come in, and patients come in and say, hey, I saw this abstract on blah, 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 and I think, should I be treated with that? And it's our job to kind of incorporate that into the bigger breadth and history of cancer care, specifically that. So I won't repeat this stuff. Dr. Dong did a great job discussing some of the biology of breast cancer. 168,000 women with breast cancer, 3 to 10% present with metastatic disease. So I said incidence rising, mortality is decreasing, and that's great. And this is broken by ethnicity. I will say that, if I'll go back here, there's both an increase in early stage diagnoses, but also an increase in metastatic disease. Why is that? Right? And there's a lot of reasons for it. Some of it I think, is that patients being younger, not necessarily expecting to have cancer. So the most common way we find cancer is the patient finds it themselves. We do screening. I can talk a whole talk on mammography and how do we do screening, but finding the lump themselves brings attention more than anything else. But if you're not looking, you have a greater chance it's going to be found in advance. Survival rates are increasing, and that is what our holy grail for all the oncologists and all the caregivers and our social workers and psychiatrists and everyone here, that's our goal. We want our patients to survive. So I want to go back, because I think it was so great having Annie before me, because to me, it's, Dr. Vanderford shared his private or his personal experience with his mom. I went into oncology because my mom got cancer. I was telling some people in the back, I was a drug rep. And my mom got cancer. I said, I want to make a difference. I saw the care that her caregivers gave her and the impact that people had. It wasn't actually the person that had the greatest impact when she was in the hospital. It was a woman who brought her lunch every day, stopped and said, hey, Jackie, how are you doing? Because we go in, you can see 70 different people in any given day when you're hospitalized, 70, depending on the hospital. So it's that human aspect. So let's just talk about this case, 43-year-old female with new onset cough, notes a fullness in her left breast. She's a non-smoker, has 3 children, and then she's diagnosed with metastatic breast cancer, metastasis to the lung. She's had surgery, chemotherapy, immunotherapy, and radiation. So I stop. What do you think her needs are? We just heard Annie. I thought she did a beautiful job of explaining that, right? And what is important? Now, one of my best friends is an oncologist, and his wife used to always tease him because when he was like this, she goes, will you eliminate your curing cancer face and just put a regular face on? Because we're supposed, we think they're in, what am I going to treat them with? How am I going to cure them? How am I going to advance their survival? Those things, and those are vital, right? That's what they're really paying us for. But it's these other things we're going to talk about. And there's people in the second row, front row here, that have a lot of experience in the realm that really we have to do. So what are they going to ask themselves? Well, how does this affect my life, right? I'm asked all the time, first question, are my kids at risk? Will I survive? That's actually oftentimes that's days and visits later. And he talked about this, your life's pressures don't stop. You still have bills, you still get a flat tire in your car, you still have other issues, your kid still needs to have a costume for the play, whatever. How do I stop crying? I can't eat. The spirituality is a part of it. Fertility, she mentioned it, that's not asked enough. What about toxicities? And actually, one of my colleagues, Leila Agarwal, gives a phenomenal talk. She focuses in the sexuality of cancer patients, because we're human beings, and that is a component of our lives. But people are afraid to ask that. And as she talked about amputation, Those all have impact. And those are things we have to consider as physicians and as caregivers. So chemotherapy, talked about the cell cycle. The chemotherapy I learned on, basically it was like if we had ants in this room, if we lit the room on fire. Basically, the chemo attacked in cell cycles, G1, all those, and it just killed all cells that were dividing. So that's why people lose their hair, the nausea, etc. But it really is hard to do. A lot of people will give up. I had patients that I saw 10 years after their diagnosis that would get to the parking lot and throw up just because remembering what they went through. So it's very, very hard. And you see here how many people get fatigue and significant daily fatigue, nausea, depression, pain. These are things we have to think about. This is why clinical research is so important, because we've got to do better. It's not just can we cure more people, that's a key part of it, but are they better off? I've had, in lung cancer in Kentucky has the highest prevalence of lung cancer and the worst outcomes. And you know what the reason is? And people are going to say, well, smoking and the mines and everything. It's patient and physician nihilism, meaning that patients are just like, I got lung cancer, I don't want to go through my grandfather. If I had $1 for every time I heard that, I don't want to go through what my grandfather went through, right? Because it's that fear of this, it's the chemotherapy. So we got to do better. And then all the other issues, and Annie alluded to some of them, but there's a lot of issues that have to be addressed. And then there's people far better geared on this than I, but there's the fear of recurrence, a lot of guilt, anger, depression, PTSD. I've seen people years after their diagnosis, and I just haven't been right. And they have PTSD, and they really have derailed their lives. So that's why if we can give drugs that are effective, yet better tolerated and easier to take, we make cancer from an episodic disease where I got to get my treatment now it's a chronic disease. I mean, I don't have many people that have diabetes who go, oh my gosh, I got it, or hypertension. That's the difference, and that's how we have to focus. All right, but here's the history lesson. This is actually the Edwin Smith surgical papyrus, the first known description of breast cancer in the history of mankind, 3000 BC. Okay, that's pretty cool. I can't read it, but I'm told that's what it says, so believe me. This is of note. So we hear about, I'm looking at all the young people in the room, and I'm thinking about my own age. So let's just go back. Does anyone know when the Civil War ended? All right, April 8th, 1865. Now you can go back to your Moorhead and all the different counties and go to your friends, and you can give me credit for it. The first mastectomy was just after that. The Hall said radical mastectomy. They took the muscles, they took the breast, they took lymph nodes, they took everything. Now think about that. Let's just pretend it was at the end of the Civil War. Civil War, right? Riding horses, doing the modified radical mastectomy was 1972. I was 9 years old then. Don't go, well, yeah, you're old. I was 9 years old. That was when we finally changed that process, right? So you think about that timeline. In 1972, does anyone know the major thing that happened that really transformed cancer care, that allowed us to do more research? Richard Nixon signed it into law, the war on cancer. Same time. That put an investment in cancer and said, we're not doing well enough. Think about that, 1972. It's crazy to think about. And then I'm not going to go through all these, but it's more of a key part in life. And this was discussed this morning, but this is kind of how we've thought about it. We kind of, there's people who are lumpers and there's people who are splitters, and we try to break it down into subtypes of breast cancer, but it was chemotherapy and hormone therapy, and that was the hallmark part of it. But as we try to personalize care, and I'm all about that, I do want to go back to Annie's story, because we just showed you that, or we talked about 1.4% increase per year in people under age 50. Well, what about the age on that? Look at our research. If you look at the research in cancer, until recently, you didn't find people over age 70 on research trials. We have diseases like chronic lymphocytic leukemia, which the median age is 72 years old, and the studies, the median age is 55. You might as well do it in a different species because it's so different. And that's how, and then in the young people, we have to think even different. This is kind of, we didn't break off AYA, we call it adolescent young adult studies, until 2006. I was blessed to be part of that just because I had trained in the Army and I had a lot of young people that were cancer patients. But you see that gold part. Every other group did better in survival other than that adolescent young adult, so age 15 to 39. And they need to be treated differently. The most common cancer in adolescent young adults is breast cancer. 14% of all cancers in adolescent young adults is breast cancer. So we need to think different. And this just gives us the relevant frequency, 15 to 39 to 40 to 65. You can see that number's increasing. And then again, this is another, I'll do quick, but it's just the drop off in survival once you start hitting that adolescent young adult range. So we're here to talk about research, but I wanted to kind of lay the groundwork as to how I look at it and what's important from that vantage point and why I think it is important. Remember, no one gets treated with any treatment without having somebody going on a clinical trial, right? And I'll say that again. So I'm going to, usually this would be the last slide, I'm going to hit it first. So to me, the key part of clinical research of any type, whether you're asking somebody to be on a survey or asking somebody to be in a biorepository or asking somebody to get on a clinical trial, is what are the goals of therapy? And this is, and we'll touch on this, but this is where, not just my goals, but what are their goals? Where are they at? What are their fears? I spend more time just trying to get to know them as a human being to understand what's important to them than, because I don't expect them to know, like, I've always wanted to be on a PARP inhibitor, Dr. Flynn, and that's why no, they come in, they're scared, and it's having that discussion and trying to find out what is important. What are they looking towards? And then if there's, some people are just like, I just don't want therapy. I listen and we talk, but I'll bring them back. I'll bring them back sooner because I want to have it's an iterative process. And then the personalized care. And we heard some great discussion this morning, but there's such an array of targets now and such an array of things we understand that we didn't know before. And I'm going to show you the history of that again, but it's so important. So now look, and these are just targets. I like cartoons, but these aren't well, you guys are like, I watch Scooby-Doo, not these cartoons, but these are, these are the different targets that we have that we can look towards. And we learn more and more and more because people went on trials. And these are things that we've been able to now look at breast cancer in a much different way. I will tell you in my career that there's people we treated in the 1990s when I was practicing that we wouldn't treat like that anymore. There's many, many women, mostly women, but some men, who went on chemotherapy that wouldn't be on it today. When we first understood that we were doing sentinel node biopsies and they had a little microscopic foci of cancer by immunologic histochemistry, and we were reacting to it, and we didn't really have the data to react, and there's a lot of people who got pretty intensive chemotherapy. Probably in this room, I'm maybe the only person that had a number of women who had radical mastectomies that I took care of that were still around. Swollen arms bigger than my leg, but they had that. So this is encouraging to me. I hope you leave here with the idea that this is encouraging times. And this gives you a perspective. 206 chemotherapy drugs approved till 2020, 39 of them of which were breast cancer. And that's all terrific. But then you look, the discoveries since 2010 have totally revolutionized breast cancer care in ways that you couldn't even imagine. When I first went into medicine many, many years ago, it is so different. And this, purposely, I didn't expect you to read the little calendar thing, but those for me, when I look at them, I think back at them like, oh my gosh, I remember that happened. I remember that happened. But now we have all these different drugs, the ADCs, and we heard about them today, the CDK4 and 6s, PARP, PI3 kinase, immune checkpoint, etc. Right? And that gives you the kind of the timelines. That's incredible in a 10, 15-year span. Think about that. The first chemotherapy for breast cancer was in 1953. 1953. Well, that was 10 years before I was born. So you'll be sitting and hopefully those that want to go into medicine and you're giving a talk, you're going to be thinking, hopefully back on, holy crow. Like when they were remember those old guys were talking about PARP inhibitors? Who would do that now? But that was the first thing. You know how chemotherapy was invented? There was a ship in an Italian harbor that had nitrogen mustard gas, which was for war. Somebody sank the ship and everyone who fell overboard, they came out and their bone marrows were wiped out. And somebody said, and they made that into chemotherapy. I'm giving you the short answer. So that's when they say the war on cancer, they're not joking. But this now, we're actually going to the microscopic level. And if you hear that, you think about that from the one standpoint of just this like hard treatments to being able to be more microscopically. It's like I say, it's like killing ants with a hand grenade in this room versus taking a fly swatter and killing them one at a time. Really exciting. All right. Only 7% of patients are involved in clinical research. About 5.5% are enrolled in clinical trials, and we'll talk about that. So people, and then 22% of patients are on multiple trials. This just gives you, when we talk about clinical research, I think about the clinical, you don't see the pointer, I think about the far left of the treatment trials, but all these things, quality of life studies, registry, genetic, we'll hear about genetics and genomics in a bit. These are all important. And Dr. Vanderford asked earlier about the difference between community and academic and NCI-designated comprehensive cancer center. They get a small grant to be focused, but that's the percentage. And I've known people that did one disease and one disease only, and they put 3 people in clinical trials a year. And I knew people that see multiple diseases and they'll put a couple hundred a year. And there's a lot of reasons for that. So this is troubling. 2 to 3% of women with breast cancer enroll in clinical trials. Now it ranges in different locations, different settings for sure. That's disgustingly low to me. And there's a lot of reasons. One of them is lack of the right trials. You have to qualify for a trial. Now I will tell you, it wasn't until the Affordable Care Act, because we did it from when I was at Ohio State, put language into that would allow for people to get standard of care covered by their insurance when they went on a clinical trial. The drug companies supply the drugs, and then the insurance covers that standard of practice. That was a huge difference. That was not that long ago, people. So until that time, it was really hard to get people on. A lot of patients don't even get offered trial by their treating physicians. I say to people, if that's the case, get a second opinion just in case. And then, if you look, about half of people, and there's meta-analyses and there's other studies, 42 to 50%, that when offered a trial, just don't go on it. And there's a lot of reasons for it. We're going to touch on those, but there's a lot of reasons. All right, so we talk about clinical trials. There's different phases of trials, and we heard some this morning. Phase 1 are basically, they're focused on safety and dosing, and it's changed a little bit. Now that we've gone to targeted therapies, oftentimes we bridge right into phase 2 because we know what the target of action is. So we're seeing response rates that are much, much higher. But phase 2 is focusing on effectiveness and further safety in a larger number. And then phase 3 trials are typically, we get in their cooperative groups, they're big multi-center studies that really compare the standard of care with this new regimen or combination. And it was discussed this morning about the preclinical, and that is really important. That understanding and all those pathways drive us forward so we know what to take to human trials. All right, so what are the barriers? Well, there's a lack of awareness. We talked about that. When your physician or your team doesn't mention that, and oftentimes it is the nurse who mentions it or somebody else or a friend. But if you don't have that, you're not going to be aware. People come in, they're scared. You tell them you need to be on this, and they're on that. So misconceptions and distrust, and that can be very specific to certain populations. Probably many people have heard of the Tuskegee experiments. So there's a distrust that we have to overcome, and that's that's something that is very important. And we have to be empathic and sympathetic, both for that situation. And we heard about transportation today, about how that can be. You imagine there's people that many of us will give $20 so they can get back home from their visit because they don't have the money for gas. And when you live in a city, you can have healthcare deserts, but you live in the rural areas, and many of you live in rural areas, right? It's 2 hours to get to a facility. So those are really important things. And then there's trial-related barriers. Some of the trials are so onerous that if you live a distance away, it's just hard to do. So we kind of touched on this. I just want to just add to we talked about, a lot of this is around the clinical trials, but I do want to talk about early detection in a moment and prevention. And then we still have to look at oncology. Historically we took a couple agents and added another one. And that's how cancer research went for the longest time. But we really need to look at more individualized treatment plans, molecular profiling, and then supportive care and survivorship. We really have to put a focus on that because people need to live well. And I thought I keep referring to Annie's talk, but I thought she did a beautiful job for that. So these I'm just going to hit quickly because we heard them. There's no real added value in going to depth, but these are the CDK inhibitors, and I had the pleasure of working with some of the early ones, and we could have a whole talk on just the process by which drug companies approve drugs and move them forward, et cetera. But suffice to say, right now there's 3 that are approved. Right, if you look going forward, a lot of the research is going to be on how do we take some of the CDK4/6s and utilize in combination so we overcome resistance, and enhance the outcomes. I want to be careful though. So some of these drugs are $10,000 a month for one. It's a pill for the rest of your life on some of our drugs. So you do that, and now you put 2 together, and I'm not a mathematician, but I think that's $20,000 a month forever. So there are limits, and we're going to have to grapple with these things, and we do when we have these discussions. And for those that are in clinical research and they're really working with it, how do you do these in a way that are truly we can do them, and we don't. Medical costs are still the #1 reason for basically going broke in this country. So we've got to be cognizant of that. And this is just some studies that are going on. I'm not going to go through them, just to show you that there are studies. We'll talk about how we access these and what we do with those going forward. Some of the immunotherapy we heard about, the PD-L1s, the checkpoint inhibitors, and there's 3 that are approved, and the mechanisms don't matter. There are plenty of studies that are open that are first line, first relapse, heavily pretreated. These are a lot of the metastatic trials that are open with these agents. And I think it's important that we understand, like whenever I look at these slides, I'm hopeful, right? This is hope to me. There's opportunities. And I tell our lawyers at Norton, when we put a trial forward, if they let some agreement sit on their desk for 2 weeks, that may be patients that didn't potentially get a life-saving drug. So move it along. The PARP inhibitors, again, it won't go into the mechanism, it's just for sake of time, but they're, again, exciting drugs. We heard about the ADCs this morning, and these really excite me. I love the idea of bringing an agent directly to the tumor that you're taking. I've done a lot of work around the radioimmunotherapeutics, where you bring an antibody attached to a small radioactive particle that causes radiation at the level, millimeters of radiation at the level of the cell. I mean, really exciting things. These are some of the studies open for that. All right, TROP2, we heard about these this morning as well, won't go into them. Again, to me, this is important, especially in breast cancer. We know that TROP2 has been, we see that with triple negative breast cancer, luminal A, and we also know that they have a role in adhesion, and there really can be an exciting target for metastatic breast cancer. They're doing a lot of work right now on adhesion, because as a cell breaks off and gets in the bloodstream and deposits a place, that's what generates the metastasis. How do you prevent that from happening? And so it's not only do you kill them, but you prevent them from going to spread. Some other studies are ongoing, again, using the TROP2 agents with other agents. And then I put this, just for purposes of this, I went to clinicaltrials.gov and I just looked for some of the metastatic breast cancer trials. And these are just, there was 3,000 that they weren't all therapeutic, but, and I think that that's important that patients do that. So if you have loved ones that have cancer, breast cancer or otherwise, they should be looking and be advocates for themselves, right? If you go in and many patients, my dad, the doctor could tell him anything, he'd be like, yes, doctor, okay, but you got to advocate for yourself, or somebody who loves you has to advocate for you. And I love it when they do that. It doesn't hurt my feelings. If they ask to get a second opinion, I usually tell them, well, you're a little overweight. No, like I tell, I'm happy to send, that's an old joke. I'm happy to send them to get a second opinion. We should feel confident in what our decisions are. All right, so looking at, so we talked about treatment kind of high level, and that's the holy grail in many ways. But if you can detect early, or you can, preventing is always better. Let's face it, if you don't have cancer, you never have cancer because it's been presented, like don't smoke, use sunscreen, all those key things. Get your colonoscopy, get a mammography, all those things, and you're able to get either early detect or prevent. That's far better than being able to be treated and having to be treated the rest of your life for cancer. So I do want to just take a moment to talk about that. So I don't expect you to read that. I just did that to say, wow, did he read that? He must be really, no. This is just on some of the mutations that we understand. So this is the second thing. I told you one thing to remember, no one ever gets a treatment without something having gone on a clinical trial. The other thing is this. I think this. There you go. All cancer is genetic. You're like, what? My parents don't have cancer. Genetics not just what you get from your parents. All cancer is genetic mutation. Something has caused a change, a genomic change in your cells that cause it to be a funny looking cell. So either it's going to grow fast, right? Not stop growing, or not look like it's supposed to, or some combination of those. So all cancer is genetic. As we can identify what those changes are, and I mentioned to Dr. Dupree about the microsatellite instability, and as we look at Lynch syndrome and colon cancer, there are those things that we have to be looking for, and if we can narrow that down so we have a better chance of catching that, the better we are, right? You're not going to go fishing in the parking lot and expect to catch fish. You're going to go to a pond that you know there's fish for, right? The better the pond, the better the fishing. And that's the same thing for us. The better we can narrow that down, the more likely we're going to be able to catch people when they're early in their disease. I mentioned self-diagnosis, right? There's only 2 reasons you don't do breast self-exam. You don't have breasts, you don't have hands, right? Everyone should do that. So it's those simple things that we have to be focused on. These are the more heritable, meaning you get from mom, dad, mutations. Everyone's heard of BRCA1 and 2, important things. And I've seen that iterative growth and change over that, but there's other things like the PALB2 and there's other mutations that we do have to be cognizant of. I have a good friend, she just had a prophylactic bilateral mastectomy because she has a genetic predisposition. And that was a very hard choice that she had to go through, and she did it, and she's glad she did, and I hope and pray that she never has any issues. But these are things we have to be focused around. And then acquired mutations, I alluded to that, but these are the things that happen over time that we can actually test for, okay? And this is where I'm going to get a little controversial, because this is an area that's coming up next. I want you at the edge of your seats, but that are things we can do that we can detect early. And we call it liquid biopsy, but it's really, we're able to actually take somebody's blood and test for some of these acquired mutations. So with great sensitivity and specificity, we can determine pretty much by the subtype of cancer whether they have cancer. Now, how do we use that knowledge? That's the real question. So what we see is we call it cell-free DNA, and it circulates in the blood, and it's released by the tumor, and you can test for that. The problem we have is if so many of these, it's not ready for prime time because we don't know if you have it in your blood and you don't show up on mammogram. I can't tell you how frequent. Should we do an MRI? Should we be checking somewhere else? Like, do I do a mammogram every month just to make sure, because these are saying you have it. So we don't know that second part. It's going to be easier if somebody has, oh, there it is, but when we don't find it, which is commonplace, we don't know what to do next. And that's where a lot of the work is happening. But in your guys' lifetime, especially the really younger people in the room, this is going to be something that's, it's here in the now. We're having discussions with the companies about how do we do this and how do we narrow it down. And we're looking at things for various cancers of how do we bring it, incorporate it into our practice in a way that doesn't cause more problems. Because the suffering of knowing that you have a 96% chance of having cancer, yet I can't find it, have a good week. You know, that just doesn't sound right. So, but this is really important. This is where a lot of work is going to be done, and we're going to be rolling this out further. And I'm personally excited about this. All right, so how do we increase our enrollment in clinical trials? This is the age-old question. NCI, NIH have dumped millions into this, millions and millions and millions to try to expand enrollment in clinical trials, yet we're still at that same 7 to 10%, sometimes less than 4%, depending on the site. So one of the things is we have to work across organizations to advance trials. That doesn't mean necessarily cooperative groups. It means cooperative groups like Dr. Dung and I, and working across the state in St. E's and UK and all of us, and we do that. We're part of KISCO together, and we do have these discussions, right? That's important. So we have to limit the competition. We've got to put the patients at the center. I will tell you, Beth Riley, I send patients, I'll call her, I'll call Rob Emmons. We don't work in the same company, but I consider them friends and colleagues, and I do that because we got to do what's best for the patient. But that's one of the barriers, it just is. And then increase awareness. People, I'm sure anyone who's tried to put somebody on trial, I want to be a guinea pig. I hear that all the time, and the answer is you're not. We don't have in cancer the studies where you're going to get a placebo versus the treatment. We don't have those. You're getting the treatment and or the treatment plus something else. So we have to educate providers. I do know of people that don't support clinical trials. That's all I'll say on that. We have to engage the communities, right? I think we have to go into the communities and have those discussions. I mentioned for our African American patients where there is a long history of legitimate reason to be questioning. We've got to go in there and really listen and try to understand and try to work to overcome that. And then I think we have to make our designs a little less onerous and a little more easy to get on more globally. I think there's some institutions, personally, I think that if Dr. Dong has a clinical trial that's open, that we should be able to open it and he gets the accruals and we work together so the patients have that continuity. And MD Anderson does that a bit in some of their trials, but I think there's things we've got to do better to that. And AI was mentioned today. I think we do have the opportunity to leverage that as we go forward. All right. So we've done some of this now in Kentucky, and we're really in our infancy to improve access to all of our patients. So right now, for metastatic breast cancer is the first one really going at. We basically, through KISCO, we started an issue. We're posting our trials for our different locations onto the website, but through a grant that we have, we've actually assigned a nurse navigator and a coordinator so that you could be in Bumbletown, East Kentucky, and call this number, and this navigator will connect you with whomever, wherever they have a study that you may be eligible for. Doesn't have to be ours, doesn't have to be in Louisville, doesn't have to, but whatever's going to be, because I'd rather you go to St. E's that has a study that can help you than to sit there and say, I can't go anywhere. So we're in their infancy, and if that works, we'll be trying to roll it out more widely, but it's really something I think is important. And I'll be honest with you, probably older people in the room remember the Miracle on 34th Street where Santa sent the people to the other store, and that was the thought behind it. It was like, let's just do what's right and we'll all benefit, but the patients will benefit, and that's what that came from. So we'll hopefully be able to follow that back up with more information. All right, so the last big part, everyone okay? Need to take a break, a drink, anything? No, we're good? Okay, so what should I ask my doctor? People, it's shocking to me. People are afraid to ask the question. No one will ever ask you, am I going to survive? Because they're afraid for the answer, and I understand that one. But no one will ask you, like no one will dare question your choice. So here's some questions. There's going to be more than just this. Do you do research here? That seems like an easy one, but that should be a question that everyone asks. And it should say do. It says, so do you encourage participation on clinical trials? To say, no, I think we're doing well enough. Not going to say leave them, but I'd get a second opinion. What types of trials do you have? Do you have phase 1, phase 2, phase 3? What does that look like? And this is, I think, the most important one. Do you have trials specifically for me in the type of cancer that I have? And I think that's an important question, an important thing that we have to really rely upon, because that is vital to know, right? That should be the key part. And one that I think that we should all ask is, if you don't have trials, do you know of trials elsewhere that I may be eligible for? And can you help me arrange? The answer is not yes, there's some at Mayo, best of luck. It's yes, there's some at Mayo. I'm going to call Dr. Bob and we're going to see if it's open so you can get some information so you don't fly. I mean, if you can't pay for gas to get to Louisville, you're certainly not going to be paying to fly to Mayo every 3 months, right? So finding those things out beforehand, those are legitimate things to ask. And then what are the requirements on me as a patient? Do I have to come in weekly to get a blood draw and then to sit there for 4 hours and I'm still trying to work, I've got kids or I'm watching my grandkids or whatever that thing is, so we need to know that. And finally, I tell people, when you go in, you should say, I want to be on a clinical trial if there's one available, plain and simple. That's what I want. And so they know exactly what's going on when you come in. All right, so I covered a whole array of different areas and different things, but again, no one goes on any treatment without somebody having been on a clinical trial, right? And people need to advocate for themselves and ask the questions. So if you want to be anyone in your town, you tell them that's what you heard. Any questions? So I know we're literally got 3 minutes, so questions that I can help answer or comments you want to make?
Yeah, my question is about research. And so randomized controlled trials, they're obviously a good standard. But I had an internship and worked in health economics outcomes research. And we looked at a lot of real world evidence. So I just am curious of your opinion on how real world evidence can be used in decision making for patients.
Yeah, thanks, Hogan. That's a great question. So I'll answer a couple ways. I think that from a randomized clinical trials, those are big, they're expensive, they're hard to do. Only about half of our trials that are opened in this country actually close to accrual. They actually fill their accruals that are set out to begin with. So there's a lot of places we can work on then. I said to you all that, I'm a fan of phase 1, phase 2 now because we're able to really, from a scientific and molecular, I know the target we're going for and we can see response rates in a different way. So a fan of that. The phase 4 part, which I don't really, you see that more in some of the hypertension, those things. We don't see that. We don't rely enough on exactly what you're talking about. But I think this is where the medical economics of research has to be taken into account. It's a great question.
So I have a controversial question, but we're all friends here. So,
yes.
So low trial accrual. What's the problem? Is it a physician problem? Is it a patient problem? Or is it an administrative system problem? Is there not enough studies? Is there not enough right kind of studies?
Yeah,
because you've made the great point that we need these, right? Because people are not going to get new therapies without more people getting on studies to make these new therapies happen. That's the best question probably of the day for all. So it's multifactorial. I'm going to give an example of part of the problem. When I was a young doctor, we treated chronic myelogenous leukemia with hydrea and transplant.
Gleevec was approved, Brian Drucker and all the great work, right, changed the hallmark of how we treat cancer, and it was approved, and a couple weeks after, the CLGB opened a trial for Hydrea something plus transplant. So it's a combination. So some of it's that, and I think we go on to the next shiny object. I think we may have too many exciting drugs that people get them. Frankly, for us at my institution, we say to companies, we will not open your trial until the other one closes that competes for the same patients. We just won't do it. Because I think too often people go on to that next thing and then they leave and they go on to what's that next piece. There's so many different factors because the patient attitude is about the same. It's probably more us than it is them. And that I think we don't have that. I mean, there should be a limit on that. And I think as it may get better as the cooperative group prominence has decreased somewhat so that we're able to really more quickly get on. I mean, really, probably most places it's the drug companies that are driving that forward. The thing that's changed there is that so many of them now go and you'll see a study opening here and in Romania, Poland, and some other countries, assuming that care is all the same. So, there's so many factors that are impacting that. But in my experience, it's kind of like I laid that out. I think we can do a better job of making sure that you don't go on to your next shiny penny until you've either determined it's not working in some of the interim analyses or it's too toxic, then move on, close it and move on. Don't leave, because for everyone here, anyone in does clinical trial, it costs us as much to keep it open, just sit there not accruing as it does to accrue. So I don't know, that's probably not a great answer, but anyone else? Dr. Singh.
Dr. Flynn, great talk.
Thank you.
You covered a lot of aspects. And since this day is all about breast cancer, so the question is, it's not a question, but I need to know your insight because you have been in this field for decades. When we talk about gender-based oncological conditions or cancers, prostate cancer in men happens late after 40s. And listening to these presentation diagnoses, in females, it starts as early as 15 years ago. I know we have more than 200 different types of cells in our body, and it's so complex how they are regulated. Plants gets cancer, animals gets cancer, human gets cancer. So where do we need reform? Why the early age in females, we are getting such cancer diagnosis so early, even they have not started a fruitful life? Where should the reform start? Is it about environment, or it is about food, or something else?
Yeah, so I'll give you my opinion. Dr. Dupree had the slide on the studies in the Japanese. We've seen it we saw it in breast cancer, but colorectal was the first one we saw that colorectal cancer you don't see in Southeast Asia. You don't see it. When they move the states, they're here for years, usually second generation, same rates as Caucasians. And so food is definitely a factor. In fact, obesity is a factor. Tobacco has always been a factor. In fact, if you look at studies, women never got lung cancer. And starting in the 1950s-ish is when we really saw that increase where there was true equality in lung cancer. So there's a lot of different factors. I think that we have to look across the board of those exposures that people have. I mean, one of my biggest concerns today is vaping. I hear 1 billion times a year, oh yeah, it's just water, it's vapor, it's water vapors with stuff in it. There's like known carcinogens in that. So we expose ourselves to those things. It's people work in the mines, people have exposures to all kinds of chemicals that that have caused that. And again, some of it is just, you can't pick your parents, and there's genetic predispositions, and So you see like Ashkenazi Jews, you see a higher propensity because the P53 gene mutations, and so there's that. And as that group stays more homogeneous, there's that increase. So it's like all these different aspects, I'd say.
Sorry, I know we're over time, but this is just kind of a small question. So you have made it clear that you really encourage patients to try clinical trials and get involved if they're able, but do you see much like distrust when it comes to like patients that come in that are like, well, why would I do that? Like it's not proven like the long-term effects of how this drug would work, and like, do you find like disarming that distrust is like difficult, or how does that conversation usually go if you're trying to encourage someone who's hesitant?
That's a phenomenal question. And by the way, you all did great this morning. I was very proud of, like I'm sure your parents would be very proud of you as well. And I don't want to sound condescending. I just was very impressed. Great question. I have a discussion. I let them know what I'm thinking. I talk about the literature as we know it. And I will say that but I make it very personal. And as Dr. Dong mentioned this morning, when my mom had cancer, there was one treatment there was available. She had it, she died, right? Today, I've been part of this teams that have discovered 8 drugs for that she would be taking a pill every day. So, I've seen the benefit of that. And it's having that understanding. Now, I don't want people to go on a trial just because we have a trial open. And I think this goes to Dr. Vanderford's question. Like, if you just make it about the trial, that's not what I'm talking about. There's so much understanding and data that goes into even the onslaught of these trials. I forget who was speaking this morning, been on scientific review committees, and the amount of work that goes into that is really remarkable. The preclinical work is unlike it's ever been. So I really feel like I can go and give good information based on their specific cancer and what their goals are. But there's some people that still their best bet is to get, if it's somebody that the standard is the best we have to offer, I will say that. The good news I have is that if we have that, typically we can have a study that has the standard plus an agent, because and I tell people, and this is, we're not curing everybody. So until we do, we can do better. That's how I deal with it. I know other people, want to comment on how they deal with it, but that's, it's being honest and having a human discussion. And that's the key. You got to build trust very quickly. As was said this morning, you're meeting them for the first time ever, and they're giving everything to you in that moment. You've got to go through that, and you got to listen, and you got to be cognizant, appreciative, and the whole family. It's a family disease. It's not just that person. So.
I think a lot of the fear and kind of like lack has come from the lack of education that we have in our area regarding clinical trials and research on it.
Yeah. Yeah, and you got to build that. It's hard to do that. Because let's face it, I'm impressed by everyone who sat here, because there's a lot of high-tech kind of advanced stuff. Imagine trying to explain that to a person who may be very uneducated from a healthcare standpoint. I'm not being condescending. There are people that it's just not their thing, and we have to do that. So I know we went over. Thank you. Thanks for letting me be here.